Hello, everyone, and welcome to our surgery session with Professor Swat Jamba. In today's video, we will be discussing a very rare case of a cervical intramedullary hemangioblastoma. Our patient was a 68-year-old woman who presented with numbness in both upper extremities along with dysphagia. She also had an ataxic walk. She was diagnosed 7 years ago, but her symptoms worsened in the last 3 months. As you can see in the preoperative MRI, there was an extramedullary mural nodule at the C1 level. The cystic superior expansion towards the brainstem can be seen. When her previous MR images were evaluated, mural nodule, cystic expansion, and brainstem compression increased with time. The mural nodule was enhanced with contrast, and an 18 mm diameter was measured with the left predominance. Her physical examination revealed weakness in the left arm and leg, along with hypoesthesia. A CT angiography is very essential in these cases, as many patients have numerous aberrations of the vertebral artery. This patient did not have any aberrations of the vertebral artery. The patient was fixated using a Mayfield skull clamp and placed prone under intraoperative neuromonitorization. With a midline incision, the foramen magnum, the posterior arch of C1, and the lamina of C2 were exposed. When exploring the posterior arch of C1, one must be very cautious of the vertebral artery. I use a dissector to feel the superior bony edge of the arch from the midline to the lateral side until a notch is palpated. This notch is where the vertebral artery usually lies, and you must not go any further lateral to this notch. Palpating the inferior aspect of the C1 posterior arcus is safe. The superior aspect of the C2 lamina was shaved minimally. Then a craniectomy was performed at the occipital bone to enlarge the foramen magnum, measuring roughly 2 by 3 centimeters. When performing a craniotomy at the occipital bone, you should be careful in trying to keep the dura intact. As the occipital bone towards the foramen magnum is thin, a diamond-tipped burr hole attachment is used. A midline incision of the dura, minimally left to the midline, was performed. The arachnoid membrane was fenestrated and the lesion with a pink-yellow color with clear borders was seen. A large drainage vein overlying the lesion was observed. However, this was not coagulated until the end of the excision to avoid venous hemorrhage of the lesion. Especially in cases of hemangioblastoma, draining veins should be kept intact until the lesion is removed completely. Otherwise, there will be a lot of hemorrhage. Using standard microsurgical techniques, the mass was dissected away from the healthy neural tissue while coagulating the feeding arteries. Finally, the draining vein was coagulated and the mass was removed as a whole. The cystic components were fenestrated to the subarachnoid space. The dura was unable to be sutured primarily, so a bovine-based xenograft was used. A collagen sponge should be placed over the graft to decrease the risk of CSF leakage while allowing for faster recovery. The post-operative period was uneventful except for a transient sixth cranial nerve palsy. An MRI image was obtained a day after the surgery where you can see the complete removal of the lesion with the spinal cord and the brain stem intact. We also obtained a 6-month control MRI and you can see there is no recurrence or any residual lesion left at the lodge.